So now let us discuss, after basic airway devices, advanced airway devices. Now advanced airway devices are devices which is used to open an obstructed airway when the basic airway devices fails, and also for positive pressure ventilation and for giving gases to the patient during anesthesia. It has multiple roles. So advanced airway devices can be divided into two types. So if you see, this is the glottic opening, this is the trachea, and this is right and left bronchus. Okay. If I put the device and the device crosses the glottic opening, then it is called infraglottic airway device. Infraglottic. Okay. So infraglottic airway device. And if we put the device and the device remains above the glottic opening, it remains above the glottic opening, then it is called supraglottic airway device. Supraglottic airway device. Okay. In supraglottic airway device, we have the pioneer device, the most commonly asked device, laryngeal mask airway to study. Laryngeal mask airway. Okay. So we'll talk about laryngeal mask airway. Apart from laryngeal mask airway, there are other devices also which comes under supraglottic airway device. There are a lot of devices. We'll talk about some other devices as well in this topic. Infraglottic airway device, we need to know about endotracheal tube. Endotracheal tube. Now, endotracheal tube, not only the routine endotracheal tube which we use, the basic endotracheal tube which we use, we will also talk about the special ET tubes which we use in different conditions. So, ET tubes comes under infraglottic airway device and laryngeal mask airway comes under supraglottic airway device. So, let us start our discussion with your endotracheal tube, the most commonest used airway device and the most primitive airway device also. This was one of the first airway device which came into existence, and it is still the commonest one which is in clinical use. So let us start our discussion with endotracheal tube. Okay. So what all we will discuss in endotracheal tube? We will talk about the first thing. I will talk about the parts of the tube. I'll show you the endotracheal tube and I will talk about its different parts and the uses of the parts. Then I will talk about how do we insert it. So insertion of ET tube, right? We need to know how do we insert it, the steps, because this is a very important, let's say, skill which everyone needs to know, and the questions are asked on skill. The clinical questions are number times asked on skill, right? So insertion of endotracheal tube, for which we need how to know how to do laryngoscopy. So we'll talk about laryngoscopy. Okay. Then I will talk about that what are the important simple physiological changes which happens in breathing with the insertion of endotracheal tube. So change in physiology when breathing through endotracheal tube. Then we will talk about adult and compare the adult and pediatric intubation. So adult and pediatric intubation comparison. So I will talk about pediatric intubation and the comparison with adult, and there itself I will show some special pediatric tube which we use. Then I'll talk about some special tubes, some special endotracheal tube. Okay. And then we'll talk about the indication of intubation. Why do we put the tube? Indication of intubation. Okay. So all these things we will talk about in endotracheal tube. So let us start our discussion with parts of ET tube. Okay. So you can see this is an image of ET tube. Okay. So endotracheal tube comes in a sterile pack. When we open this sterile pack, inside this is this endotracheal tube. You can see the image also. I'm holding it in my hand also. So I will just name the parts. So it has two ends, definitely. One end will go in the glottis. This is called glottic end, and this end is attached to the circuit. This is called circuit end. So I will go from glottic end towards the circuit end. Okay. So this is the glottic end, and the glottic end of the endotracheal tube is B-weld. B-weld. Okay. It is not complete. It is B-weld. As you can see, it is B-weld. Okay. Just beyond the glottic end, there is another opening in the tube. This is the other opening, okay? So this is the main opening from which I am inserting my pen, and this is the side openings in the wall of the tube. There are some tubes without this side opening also, that's called Magel tube. I'll talk about it. So this is called Murphy's opening, okay? So after that we have cuff, right? Cuff in the endotracheal tube. You can see this cuff with a pilate balloon system to inflate it. We inflate the cuff and through filling air through this pilate balloon system, and this gets inflated and forms a seal in trachea. So we'll talk about this cuff, okay? So we'll talk about this cuff, okay? Then you can see there is black mark on the tube. There is a black mark on the tube. This black mark guides us till what extent we have to insert the tube. So we have a black mark, okay? Then the internal diameter of the tube is written on the wall of the tube. This is the internal diameter written. See, the tube is sized according to its internal diameter, okay? Then it is written, it can be used both for oral and nasal. It is single use, and then markings on the tube showing its distance in centimeter from the glottic end. And this is the universal connector, okay? So universal connector which will universally connect it to the circuit. See, this tube can be of any internal diameter, but the universal connector is of same diameter to universally connect it to the circuit, okay? So these are the important parts of the tube. One by one we will discuss the part. So let us first discuss the beveled end, okay? So first part was the glottic end, which I told you is beveled, okay? You can see this, the bevel is left facing. I am holding it in my right hand, it is left facing, okay? The beveled is left facing, as you can see. Why is this beveled end present? One, for the easy penetration of the tube, and other, to minimize the obstruction of our view when the tube crosses the glottic opening. So when the tube is crossing the glottic opening, since this is incomplete beveled, we will have a clear view of tube crossing the glottic opening. If it is a right facing bevel, then our vision will get obstructed. So it is not right facing, it is left facing. So bevel is, the second point, bevel is left facing, okay, always, because we hold the tube in our right hand, the dominant hand. Mostly the maximum population is your right handed, so it's left facing. Why we have beveled end? It helps in clear visualization, of ET tube crossing the glottic opening, ET tube crossing the glottic opening, okay? So remember about the bevel end, okay? After bevel end, we have something called Murphy's eye in the wall of the tube. You can see this. We talked about the Murphy's eye. Now this is an alternate opening. If the main opening gets obstructed, we can ventilate through Murphy's eye. So this is alternate opening. This is alternate opening, okay? Alternate opening for ventilation, right? Okay. Now remember this, Murphy's eye, there are some tube without this Murphy's eye, and they are Magel tube. So Magel tube do not have Murphy's eye. Magel tube are without Murphy's eye, okay? So remember this, Murphy's eye, okay? Now after that, as I showed you, there is cuff, okay? So we have three tube image in the image, three tubes in the image. This first one is cuffless, and the second and the third one has cuff. Now this is a round shaped cuff, and this is a cylindrical cuff, and this is round, okay? The cuff has the same role, whether it is cylindrical or round. I'll just talk about both the cuff. So this is trachea, this is right and left bronchus. When I insert the tube and through the help of this pilate balloon, we inflate the cuff. The cuff forms a seal in the trachea. It forms a seal in the trachea. And now, no oral secretion will go in the respiratory tract, and neither there would be the loss of gas when we are ventilating. It creates a seal for positive pressure ventilation. So, what is the use of cuff? Use of cuff. Now, cuff has two important roles. Number one, it creates a seal for positive pressure ventilation and it prevents aspiration. So, it creates a seal for positive pressure ventilation. Positive pressure ventilation. Okay. And second, it prevents aspiration. Prevents aspiration. Okay. Now, this cuff is of two types. The low pressure, high volume, that is cylindrical cuff. So, I talked about this cylindrical cuff. When we inflate it, it has a multiple site of attachment with the tracheal wall. This generates a low pressure and high volume. The volume, whatever volume we insert, it will not have a very high pressure exerted on the wall of the trachea. So, risk of tracheal ischemia is less, tracheal stenosis is less. Then we have the round one, the high pressure, low volume cuff. Okay. So, since we know today what is exactly the pressure applied on the tracheal wall with the cuff, which would help in preventing aspiration, we prefer low pressure, high volume cuff. So, more common which we are using is low pressure, high volume. Low pressure, high volume. Okay. So, low pressure, high volume cuff is more commonly used. The optimum cuff pressure which is required can also be fulfilled by this optimum cuff pressure which is required to prevent aspiration is 18 to 24 mm of Hg or 25 to 30 centimeter of water. Okay, in 2 units I have given 18 to 24 mm of Hg or 25 to 30 centimeter of water. Okay, so this is how the use of cuff, and we are using more commonly low pressure, high volume cuff. Now, high pressure, low volume cuff is used in some special tubes like your laser tube, where we want a very high pressure and no gas to escape in the oral cavity where the laser is being used because there is a risk of fire. Okay, so we talked about cuff. Then let us talk about this black mark. Now, what is the use of this black mark? See, this black mark, the use is that when we are inserting the tube, we leave the black mark on the glottic opening. Then the tip of the tube, the glottic end, would remain above the crina. So, if you see, this is your trachea, this is right and left bronchus, this is the crina, right? We want to keep the tube above crina. We don't want to make it endobronchial. Then only one lung will get ventilated. And even if it is touching the crina, the risk of stimulating lot of reflexes would be there. So, we try to keep it above crina. How do we keep it above crina? We don't see crina, we only see the glottic opening. We are helped for this by leaving the black mark just on the glottic opening. When we do this, the glottic end remains 3 to 4 centimeter above crina, which is the optimum position. 3 to 4 centimeter above crina, right? 3 to 4 centimeter above crina. Okay, and this is the optimum site for the end of the endotracheal tube to remain. Okay, 3 to 4 centimeter above crina, and this is held by this black mark. Okay, now let us talk about the universal connector. So, this is the universal connector. This is 15 mm of internal diameter 15 mm to attach to the 22 mm internal diameter end of the circuit. So, this is your universal connector. Okay, this has 15 mm internal diameter to attach it to the 22 mm circuit end. Okay, so this is how the parts of the tube. And then remember, the tube has a blue line, continuous in entire length. There is a blue line. This is a radio opaque line. So when we put the tube and we get the X-ray done of the patient, we can visualize it in the X-ray. Okay, so this is how it should be. It would appear when we are seeing it in the X-ray. Okay, so this is because of the blue line. So blue line, a radio opaque line, right? For radio opaque line for visualization in, for X-ray visualization, right? So whenever our patient is in ICU intubated, we always check the right position. It should be above crina. It should, so here this is the crina, here the right and left bronchus division is happening. So it should be 3 to 4 centimeter above crina. This is the right placement. Okay. So this is the blue line. Sizing of the tube, right, is done through the internal diameter. So we choose the right size of the tube. How do we choose? I will talk about the right size in adult and in adult male, adult female, and it is sized according to internal diameter. Okay, tube is sized according to internal diameter. How do we insert this tube? You can see it is written on the tube, oral nasal. So definitely endotracheal tube can be inserted through oral cavity. We call it orotracheal intubation, or inserted through nasal cavity. We call it nasotracheal intubation. Nasal cavity, as I talked in the basic airway also, is a very vascular. So we don't want to touch it until and unless it is mandatory that we need to touch it. So orotracheal intubation is more common, and I'll talk about orotracheal intubation. So insertion of ET tube we can do through orotracheal intubation, okay, or nasotracheal intubation. Which is more common? Orotracheal intubation. This is more common. So first let us talk about orotracheal intubation, for which we need the help of the device. What is this? This is a laryngoscope. Okay. So this is laryngoscope, a device which will help us in orotracheal intubation. We intubate the patient under full visualization of glottic opening. You can see this has a curved blade. It has a curved blade. Now this laryngoscope with the curved blade, this is Macintosh laryngoscope. And this Macintosh laryngoscope is the commonest laryngoscope which we are using, right? Even in adult and pediatrics, both, even in pediatrics, right? So because this is the more common laryngoscope we practice on, and worldwide Macintosh is the commonest one which is being used, and it has a curved blade. So what are the steps of laryngoscopy? So we will talk about orotracheal intubation, steps of laryngoscopy. Okay, so steps of laryngoscopy. So first thing in the step laryngoscopy to insert the tube is position. You make a proper position. Okay, so what is the position which we made for laryngoscopy? So position for the laryngoscopy, this is the position. This is called morning sniffing position. Okay, when in the morning the weather is very good and you want to take the fresh air, how do you take it? This is the morning sniffing position. Okay, when this sniffing position is made, there is extension of atlanto-occipital and flexion of the cervical spine. Okay, flexion of cervical spine, extension of head. So morning sniffing position. Morning sniffing position is what position is laryngoscopy position. This is also called barking dog position, barking dog position, or Jackson Chevalier's position. Jackson Chevalier's position. Jackson Chevalier was the first person to design the laryngoscope. He came up with the concept of laryngoscope. So on his name also this position is described. So morning sniffing, barking dog, or Jackson Chevalier's position. So this is the position of laryngoscopy. And in this position, head is extended, and neck is flexed. Neck is flexed. Okay. So cervical spine is flexed. Atlanto-occipital joint is extended. This is morning sniffing position. Okay. Then what do? We hold the laryngoscope in our left hand, right? So the second step is that we hold laryngoscope in left hand. Always the Macintosh laryngoscope is held in left hand. Okay. See, the maximum population is right-handed and the airway device should be held in the dominant hand. So the laryngoscope was designed in such a way that you have to hold it in left hand. Later on, for the left-handed person, they designed a new laryngoscope which was to be held in right hand so that their dominant hand is free to hold the airway device. But that is not so common in practice. So what is there? Macintosh laryngoscope. So we all have to hold it in the lefty or the righty in the left hand. So hold the laryngoscope in left hand. Then insert it from right angle of mouth. So insert laryngoscope from right angle of mouth. From right angle of mouth. Okay. So after insertion from right angle of mouth, when you open the mouth, what is the structure you see? Tongue. So you push the tongue out of the way by moving the laryngoscope from right end to the middle. So when the laryngoscope is moved from right to middle, the tongue is pushed from middle to left side. So move the laryngoscope from right to middle. When we do so, what do we see? The tongue is pushed. So tongue is pushed and we visualize the epiglottis. Tongue is pushed, epiglottis is visualized. So when epiglottis is visualized, what do? We take the laryngoscope to the base of the epiglottis where it is attached to the arytenoid or to the arytenoid, that is array epiglottic fold, or to the glossoepiglottic fold, and we hinge the tip of laryngoscope in array epiglottic fold or glossoepiglottic fold and lift. Right, the movement is on the elbow joint, not on the wrist joint. So we lift and the epiglottis gets lifted up. So when the epiglottis is visualized, what do? We take the tip of laryngoscope to array epiglottic fold or glossoepiglottic fold. Laryngoscope to array epiglottic fold or glossoepiglottic fold. Okay, and lift the laryngoscope. When you will do this, right, when we lift the laryngoscope, the epiglottis will get lifted up and the glottic opening will be visualized. So this is the glottic opening. This is the epiglottis in front of it, and in front of them is tongue. So tongue is pushed to left side, epiglottis is lifted up, the glottic opening will be visualized. So when the glottic opening is visualized, I hold the tube in the right hand, the dominant hand, and under full vision I insert it, right? So lift the laryngoscope, what will happen? The glottic opening will be visualized. So glottic opening is visualized. Okay, visualized. So how would the glottic opening look like? So when I will do laryngoscopy, I could see the glottic opening. This is the glottic opening. This is the vocal cords. This is the rings, cricoid ring, and this is the opening. Okay. So this epiglottis gets lifted up and this opening is visualized. So I have to see this glottic opening. Okay. This is interarytenoid notch. We just have to visualize the glottic opening. So when you will do the laryngoscopy, you can do the Konmak-Lehane grading. This is Konmak-Lehane grading. That is how much the glottic opening is visualized. So grade 1, the entire glottic opening is visualized like this. And grade 2, only the posterior part of the glottic opening is visualized. Only this much is visualized, not the anterior part. Then grade 3 only the epiglottis is visualized, and grade 4 only the hard palate is visualized. So if it is grade 1 and 2, easily we can insert the endotracheal tube. So we will insert the endotracheal tube holding it in our dominant hand. So insertion of tube. So insertion of tube, endotracheal tube. So we hold the tube in the dominant hand, hold the ET tube in right hand, insert it, leaving black mark on glottic opening, black mark on glottic opening. So we leave the black mark on glottic opening. Okay. After that, what do? We, very important, inflate the tube. Inflate the cuff of the tube, cuff of ET tube. After inflating the cuff of ET tube, what do? See, we will inflate the cuff of ET tube. After this, what we will do? We will check for the right position of the tube. So next is, we have to check for the right position of the tube. So check for right position of tube. So there are various ways of checking right position of ET tube. The most confirmatory is your capnography. So capnography is a sure shot technique, is sure shot method, is sure shot method of confirmation, method of confirmation. Okay. So we do capno, we attach the capnograph, right, where between circuit and ET tube. And if in the capnograph we get a proper graph like this, then it is 110% confirmed tube is at right place. If we don't get a graph, then it is esophageal. If we get a graph, then it is tracheal intubation. Now there are other ways of confirmation also. We do a 5-point auscultation, 5-point auscultation. Okay, so we do a 5-point auscultation. Then we can also confirm by seeing the expiratory gas leaving the mist or vapor on the tube, right? Expiratory gas is heated and humidified. So visualize expiratory gas leaving vapor on ET tube. Then there are other ways which are not very quick ways but can be used. Fiber optic bronchoscopy, fiber optic bronchoscopy. Now this is also confirmatory, but it is not something which we do immediately. So sure shot, still we have to answer capnography. Okay, and then chest X-ray, chest X-ray. Okay, so this is the ways of checking the right position of ET tube. So once the right position is confirmed, then only we tape the tube, we secure the tube. So secure the tube, secure the ET tube after confirmation of right placement, after confirmation of right placement. Okay, so secure the ET tube after confirmation of right placement. So once it is confirmed that it is rightly placed, we secure it with the adhesive tapes. Okay, so this is how the endotracheal intubation is done, orotracheal intubation is done. Okay, so these are we need to remember the steps very. So let us revise the step. We do laryngoscopy. After that, we visualize the glottic opening. So glottic opening is visualized. We put the tube. So just in a crude way I am saying, put the tube. Then inflate the cuff. Inflate the cuff. And then we confirm for the right placement. Confirm right placement. And then secure. Right? So this is how the steps, right? So we have discussed the different steps of laryngoscopy. So laryngoscopy intubation done. So if someone is breathing through ET tube, right? So what would be the change in the physiology of ventilation? This is something which we need to discuss, right? So change in the physiology of ventilation. We'll talk about first and then I will talk about adult and pediatric intubation. Okay, so let us talk about that change in physiology of ventilation. Physiology of ventilation with ET tube, with endotracheal tube. Now, two important basic changes. Number one, dead space is decreased. Dead space is the space which O2 CO2 exchange should not take place. No? So it is from the upper airway to the respiratory bronchiole. From terminal bronchiole onwards, the exchange starts. And maximum contribution of dead space is from the upper airway. So when you put the tube, you bypass the upper airway. So dead space is decreased. This is a benefit. The second is the resistance to the breathing increases. This is a demerit. So resistance increases. Resistance to breathing increases. Okay. Why? Why this happens? Now this is the cross section of trachea through which the air will pass naturally, and this is the cross section of trachea with endotracheal tube. So now the diameter of the area through which the air is passing decreases. The resistance will increase. We all know resistance is inversely proportional to the radius power of 4. So mostly it is the radius, the diameter, which is responsible for increasing the resistance to the breathing. So diameter decreases, resistance increases. Okay, this is the main reason of increase in resistance. Length of the tube is more, then also resistance increases. But normally all adult tubes are of same length. It is the diameter which varies. In pediatrics, the length also matters, so normally we cut the tube. But remember, diameter, the radius, this is the most important. This is the most important to increase the resistance. This has been asked so many times, right? Even if the tube, bent tube we are using, the resistance will be more. But keeping all the other factors constant, it is the radius and the diameter which is affecting the resistance most. And that also by 4 times. Okay, so remember this. Now let us discuss the difference between adult and pediatric intubation. Okay, so how is the airway of a pediatric patient different from adult? So this is adult and this is pediatric. You can see the difference is very evident. Pediatric patients have a very prominent occiput. They have a short neck. So this prominent occiput and short neck makes it very difficult to make them in a morning sniffing position. Morning sniffing position would exaggerate the flexion. So in pediatric patient, we keep the head and neck in a neutral position. We don't make a morning sniffing position. Okay. Then the mouth opening of pediatric patient is small compared to adult. So it's very difficult to insert a proper size laryngoscope. Anyways, we insert it. Then the tongue. This is the tongue of adult. This is the tongue of the pediatric. This is longer and broader. So it occupies a major portion of the oral cavity. So they have a disproportionately large tongue compared to the oral cavity. So it is very difficult to push it out of the way. Then their larynx is high up against C3, C4. Adult, it is against C4, C5. Pediatric, it is high. So it is at an angle. So difficult to visualize it. Then the epiglottis. The epiglottis is of the pediatric patient that is longer and the leaf life. If this is the adult epiglottis, this is the epiglottis of pediatric. Longer and leaf-like, right? And the narrowest part of the adult airway is the glottic opening, right? But the narrowest part of the pediatric airway is subglottis. Their airway is mostly funnel shaped, and the adult airway is cylindrical. So these are the changes. This makes pediatric intubation little difficult. So their occiput is prominent, neck is short, oral cavity is small, tongue is disproportionately larger. They have a high larynx against C3, C4 compared to C4, C5 in adults. Then their epiglottis is longer leaf-like, and the subglottis is the narrowest portion, not the glottic opening, right? So because of these differences, we practice two let's say uniform changes in during pediatric intubation, right? Two standard changes are practiced. So first change, in pediatric, we use this straight blade laryngoscope. This is your Miller's laryngoscope. Miller's laryngoscope, right? Or straight blade laryngoscope. Now this laryngoscope, what would be the benefit? Like in adult, we also make proper, keep the head and neck in the neutral position compared to adult, where we make morning sniffing position. In pediatric, hold the laryngoscope in left hand, this straight blade laryngoscope, insert it from right angle of mouth, then we push the tongue and we see the epiglottis. Now when we see the epiglottis in adult, we take the laryngoscope to the base, the epiglottic fold here, right, and we lift it. The epiglottis gets lifted up and the glottic opening is unveiled. But in pediatric, lifting up the epiglottis will not unveil the glottic opening. So we take the laryngoscope to the tip of the epiglottis and we lift it. So whole epiglottis is lifted up with this straight blade laryngoscope. So this is used in pediatric to lift epiglottis, okay, right? Today even the curved blade is used in pediatric. It depends upon what you are used to. But Miller's laryngoscope was specially designed for pediatric patient to lift up their epiglottis. The other problem is that subglottis is the narrowest part of the pediatric patient. So normal ET tube, which has the cuff, this cuff was causing subglottic trauma. So for pediatric, this uncuffed tube was designed. Uncuffed ET tube. This is uncuffed ET tube, does not have a cuff. So when this tube was inserted, this was not causing any obstruction at the subglottic level. Okay, it was not causing any obstruction at the subglottic level. So subglottic edema was minimized. So in less than 5 to 7 years, this uncuffed tube is used to minimize risk of subglottic edema. Okay. So as I told you, in pediatric, we use straight blade laryngoscope. This is a straight blade or Miller laryngoscope, and this is the curved blade, that is Macintosh laryngoscope. So this is used in adult more commonly, and this is used in pediatric. In pediatric, we are using this uncuffed tube to minimize the risk of subglottic edema. So these are the two standard changes which we do in pediatric intubation. Okay. Now let us talk about some special tubes. So we'll talk about some special ET tube used in special circumstances. Okay. So first special tube which I'll talk about is your flexometallic tube. Now this is your flexometallic tube. Okay. If you see this tube, this flexometallic tube, this tube has a metallic wire on its inner circumference. So if I fold this tube like this, if I fold it like this, let's say the inner diameter or inner circumference is maintained. It does not get obstructed because of the metallic wire. If I fold this tube, you can see then obstruction happens. So it cannot maintain the patency when it is bent. Okay, but this tube, even if when it is bent, it can maintain its patency. So this tube is basically kink resistant. Okay, so first special tube which I am discussing with you is flexometallic tube. Okay, flexometallic endotracheal tube, or we call it reinforced tube. Reinforced because it is reinforced by a metallic wire. So reinforced ET tube, or we call it armored ET tube because like a soldier, it also has an armor. So armored ET tube, its metallic wire is its armor. So this is the armored tube. It has on its inner diameter a metallic wire. This has made it kink resistant. Okay. So since it is kink resistant, wherever there is a risk of kinking of the ET tube, we use this tube. So where there is risk of kinking, in neurosurgery, where the drape etc. is on the tube and we are sharing the airway area with the surgeon and we don't have easy access to the tube. Head and neck surgery, where the tube would go in the surgeon's let's say, in number of, let's say, apparatus which the surgeon used for opening the mouth, etc. Then for prone position, where the patient is made in the prone position, because of the pressure on the tube, it can get kinked. So we are using it at anywhere where there's a risk of kinking, right? So remember, this is kink resistant, and this is tube of choice for neurosurgery, for head and neck surgery, for dental surgery, right? And for prone position also, and anywhere where there is a risk of kinking of the tube. So this is your flexometallic tube. Okay. The next tube which I would discuss with you is your double lumen tube. Double lumen tube. Okay. So let me pick up the double lumen tube of mine which has fallen down. So I'll pick up the double lumen tube. So this is a double lumen tube, right? You can see it has two lumens. This transparent one is the tracheal lumen which ends here, right? This is the one lumen which ends here, and the second lumen, the blue one, which ends little further. Now this has two lumen. One lumen will end in trachea, and other will go into one of the bronchus. So we can ventilate only one lung by clamping one of the tubing of this double lumen tube. So we can use it for one lung ventilation. So this is double lumen tube. This is used for separating one lung from another, right? So this is used for one lung ventilation. One lung ventilation. Now, as I told you, it has two lumens, a tracheal and the bronchial. So bronchial lumen can be left facing or right facing. If it will go in the left side of left bronchus, it's left double lumen tube, right double lumen tube. So bronchial and the tracheal. Okay. This is used for one lung ventilation, lung separation in case of hemoptysis, etc., or infection in one lung, severe infection in one lung. Okay. We sometimes use it for differential ventilation also. So this is double lumen tube. Now, very important. When we insert it, one of the lumen goes into one of the bronchus. We all know that the bronchus divides into upper lobe division, middle lobe, and the lower lobe. The right bronchus specifically, its upper lobe division is at a very early of the right bronchus. So when I am putting the right double lumen tube, right-sided double lumen tube, so when I am putting right-sided double lumen tube, what happens? There is a high risk that it can go deep. This tube can just, let's say, bypass the upper lobe division, and only the lower lobe and the middle lobe will get ventilated. So only two lobes, or mostly only one lobe, will get ventilated. So ventilated area becomes less and less. Risk of hypoxia and hypercapnia would increase. So this is the mal position. We don't want it. We want to keep it above the 3 division. But we cannot see the 3 division when we are blindly intubating after passing the tube. So it is mandatory that whenever, especially when we are putting right-sided double lumen tube, we do a fiber optic bronchoscopy and see the distal end of the tube. If it is too deep, we pull it. So fiber optic bronchoscopy is best way for confirmation of right placement of double lumen tube. You don't need fiber optic bronchoscopy for normal tube, but for double lumen tube it is mandatory. Okay, so this is double lumen tube. The next tube, this is your laser tube, laser ET tube. This is used in laser surgery where there is a high risk of fire. The tube is made up of, normal tube is made up of polyvinyl chloride. This is highly inflammable. So this, what is done, the 2-layer wrapping is done on the PVC tube. Inner metallic wrapping and outer non-reflecting wrapping, so that this does not come in contact with the lasers. and the fire is inhibited. Otherwise also in the laser tube, we have a high pressure cuff to prevent any air to escape and go in the upper airway, because we are giving oxygen and nitrous oxide, both supports combustion. So it has a high pressure cuff, and some of the laser tube have two cuff for a better seal. Okay, so if this is your airway, you have put the laser tube, we have inflated the cuff, we are ventilating, there would be no risk of air escaping in the oral cavity where the laser is being used. So if the laser will get the gases like oxygen etc. in its surrounding, chances of fire would be more. So this is the laser ET tube. Okay, so these are the special ET tube I wanted to discuss about. Now let us discuss the indication of intubation. Indication of endotracheal intubation. The most important indication is why I intubate daily during general anesthesia for positive pressure ventilation and for giving our anesthetic gases. So during general anesthesia, okay, so during general anesthesia, we intubate our patient. Then next is for positive pressure ventilation when the airway of the patient is compromised. For positive pressure ventilation, any reason patient is unable to maintain his oxygenation, ventilation, we put the patient on ventilator by putting the tube. We always have to put ET tube, cuffed ET tube for positive pressure ventilation to create a seal. Then to protect the airway from aspiration, to protect airway from aspiration. So patient can breathe but does not have ability to protect the airway. So protect the airway from aspiration. So number of head injury patients are electively intubated to prevent aspiration. And then for pulmonary toileting, that is patient is unable to cough and take out his secretion. We intubate and we try to we intubate the patient and we do suctioning and remove the secretion. So these are the basic indication of intubation, right? So endotracheal tube is the first device which I discussed with you, the advanced airway device. Now the other airway device which I will discuss with you is supraglottic airway device. So after endotracheal tube, let us talk about supraglottic airway device. And as I told you, supraglottic airway device remains above the glottic opening. It does not cross the glottic opening. That's why it is called supraglottic airway device. So let us see an image of supraglottic airway device. So this is a supraglottic airway device, classical laryngeal mask airway. This is prototype of supraglottic airway device. So supraglottic airway device, they remain above glottic opening, And the first device which I would discuss in this would be classical laryngeal mask airway. Classical laryngeal mask airway. Now this device was designed by Dr. Archie Brain. Dr. Archie Brain. Okay. So that's why it was also called initially Brain's LMA. Right. It is popularly called LMA, the classical LMA. This was also called Brain's LMA. Okay. Now let us talk about Brain's LMA or classical LMA. See, this is the cuff. So this is cuff. This cuff has this pilate balloon system to inflate it. So it can be inflated by this pilate balloon system. So we can put air and this cuff will get inflated. Now this back portion is the dorsal part of the classical LMA, and it does not have any opening in it. On its ventral side, there is a opening. This is opening, and this has two, let's say, ridges to lift the epiglottis from falling on it, to prevent the epiglottis from falling on it. Okay, so opening with vertical ridges, vertical ridge. Okay, and if you see this opening, this is connected with this tube. Okay, so I can insert my pen also through it, and this is the tube to which it is connected. So this is airway tube, and this airway tube has this universal connector like the universal connector of your endotracheal tube. So universal connector. Okay. So how do we insert it? Like any other airway device, it is held in the dominant hand. So if you see the image 1, how do we hold it? We hold it in pen holding fashion. So I am holding it in a pen holding fashion, and then I open the mouth of the patient, and with pressure applied through my finger, I just make it flat on the posterior pharyngeal wall, and I make it flat and start applying pressure down, 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 down. So I start applying pressure with my index finger. I insert it. It follows the path of the least resistance, as you can see in the 2. And when I push it, and now I cannot push it any further. I am facing a maximum resistance. I take my hand out, I hold it, and then I inflate the cuff. It comes little out for a right positioning. Now what happens? This opening is against the glottic opening, and this tip goes into hypopharynx. So you see, this is the tip which is blind. This tip is blind, doesn't have any opening, is in hypopharynx, right? And the opening is against your glottic opening. This is against glottic opening. So this is the proximal opening, this is the distal opening, and through which we can ventilate the patient. So this is against glottic opening. Okay. So this is our classical LMA and the method of inserting it. So as you can see, we do not require any laryngoscope to insert it. We just open the mouth, push, 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 push. So if you have gone through how do we insert the endotracheal tube with the help of laryngoscope, for inserting endotracheal tube, we need to have little knowledge of the anatomy of the airway, how to hold the laryngoscope, what all we have to see, etc. But here, we don't have to do anything. We just have to open the mouth and push, 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 push. It goes and sits at the right place. Studies have shown that even a naive inserting it would go and sit at the right place in 99% of the time. So it is very, very, very easy to insert and very quick to insert. So let us write some of the benefits of classical LMA. Okay. First, it is easy to insert, as just now I demonstrated. Easy to insert, fast to insert. ET tube insertion would take more time than LMA insertion. Fast to insert. Then does not require laryngoscope, so no laryngoscopy response, no sympathetic stimulus. So it is a less invasive air device. This cuff is a very soft, made up of very soft silicone material, easily tolerated. So less invasive, so less complication. Okay, all these are the benefits, but the major issue. So when you put the tube, we all know tube has a cuff. So when I am putting endotracheal tube, the tube cuff, when it inflated, it creates a very good seal in the trachea, 99.9%, no risk of aspiration. But when you are putting this, it is also creating a seal over the glottic opening. But the seal is not strong enough to prevent aspiration. The major drawback, aspiration cannot be prevented. So the major drawback of classical LMA, major drawback of classical LMA is that aspiration cannot be prevented. Aspiration cannot be prevented. So if aspiration cannot be prevented, we cannot use it as a definitive airway. So how do we define a definitive airway? Let me define a definitive airway for you, right? So definition of definitive airway is that the device which can be used for ventilation and can also be used to prevent aspiration. So it has to do both the job. So a device, an airway device, which can ventilate and prevent aspiration, which can ventilate and prevent aspiration, right? So any device which can ventilate and prevent aspiration is definitive airway device. Okay. And LMA can ventilate but cannot prevent aspiration. Classical LMA. So it is not a definitive airway device. So the major demerit, the other demerit, cannot be used for a long time period. Not a definitive airway device. Okay. So this is the demerit. So Dr. Archie Brain, who designed this device, noticed this demerit. So he came up with the second generation supraglottic airway device. So we were talking about classical LMA, right? Now this classical LMA is first generation supraglottic airway device. First generation. And this cannot prevent aspiration. Dr. Brain came up with second generation. And now we will talk about this LMA ProSeal. Second generation supraglottic airway device. LMA ProSeal. This is LMA ProSeal. How it is different from classical LMA? It has a cuff and an airway tube like classical LMA, but it also has a gastric tube which ends right on the tip. So through this gastric tube, I can even put a Ryle's tube through it. It has a ventral cuff and it has a dorsal cuff also to give a very good seal. It has an airway opening and a gastric opening. So everything, in the second generation we have two. We have two openings, we have two tubes, the airway and the gastric tube, and we have two cuff for a better seal. So this device became comparable to ET tube in preventing aspiration. So second generation supraglottic airway device, this is LMA ProSeal. Now LMA ProSeal has airway tube. This is the airway tube. This is the gastric tube. This is the ventral cuff and behind is the dorsal cuff. This is the gastric opening. This is the airway opening. Okay. And about this, I want to tell you that it has all the benefits of classical LMA. Easy to insert, fast to insert, less invasive, and it is comparable to endotracheal tube in preventing aspiration. It creates a very good seal in preventing aspiration. Now insertion, everything is same. Okay. So it is comparable to ET tube in preventing aspiration. So this is the benefit of your ProSeal LMA. So we talk about ProSeal LMA, which is comparable to ET tube in preventing aspiration. Now there are other second generation supraglottic airway devices also, which I'll talk about. Now if you see this is iGel airway. iGel airway. This is also second generation, and this is also comparable to ET tube in preventing aspiration. Now this is a iGel airway. Now you cannot see any the inline tubing for inflation of the cuff. This has a non-inflatable cuff made up of a special polymer. So this is cuff non-inflatable. This is made up of special polymer. Now again, this is very easy to insert and very quick to insert like other supraglottic airway devices. This is also second generation. So this is also comparable to ET tube in preventing aspiration. Now whether it is your classical LMA or ProSeal LMA or iGel, now all three comes in sizes for both pediatrics and adult. So how do we decide the size? So size is decided by weight in kg, okay, and size of LMA. Now endotracheal tube, the size is decided by the age. Here the size is decided by body weight. So weight in kg, size of LMA. So less than 5 kg, we have size 1. 5 to 10 kg, we have 1.5. 10 to 20 kg, we have 2. 20 to 30 kg, we have 2.5. Then 30 to 50 kg, we have size 3. 50 to 70 kg, size 4. More than 70 kg, 5. And more than 100 kg, 6. So total 8 sizes. 8 sizes for all the 3 devices, the classical LMA, the ProSeal LMA and the iGel. So all the 3 devices, the main devices which we use, we have all the sizes available. Okay. We all know the ET tube size is decided according to age. So for endotracheal tube size, adult male, in adult male, we go for 8 to 8.5 internal diameter in millimeter. For adult female, we go for 7.5 to 7.5, right? Internal diameter in mm. Okay. So this is how we go for sizes in adult male and adult female. We can go for even a bigger size if we see during laryngoscopy that glottic opening is very big. So it depends on the age we choose the right, but this is the common size which we are using. Okay. For nasal, one size less is used. Okay. So ET tube, the sizing is according to age. Here the sizing is according to body weight. Now ET tube, we discussed 4 uses during GA, for let's say positive pressure ventilation, for pulmonary toileting, for your to prevent aspiration. Now what are the uses of your LMA? So uses of LMA, all the supraglottic airway device, not only LMA, of supraglottic airway device, right? First generation, second generation, all supraglottic airway device. Now with advent of second generation, the use of LMA has expanded. First, we can use it as an alternative airway device to ET tube during GA, right? Especially the second generation. So for general anesthesia, we can use during general anesthesia. So this is one use, but the main use for which it was designed by Dr. Brain as a rescue device during difficult airway situation. So as rescue device during difficult airway. So when we are not able to put the tube, right, difficult airway, we have discussed this is easy to insert, fast to insert. So it is a very good rescue device during difficult airway. This was the reason for its advent. Okay. Then it can also be used for other purposes like an aid in intubation. There is an intubating LMA which helps in intubation as an aid in intubation, right? So its work area has increased with different kind of LMA available. As an aid in intubation, we use intubating LMA, the LMA through which the tube can be inserted, intubating LMA, or ILMA we call it, or fast track LMA. Through this LMA, right, this is a special LMA through which you can put a endotracheal tube also. Okay. So intubating LMA or fast track LMA. So these are the different uses of supraglottic airway device. Now supraglottic airway device very well replacing ET tube for general anesthesia where there is no risk of aspiration. Only where there is a high risk of aspiration like emergency surgery, patient is not full NPO, we are using endotracheal tube. But for most of the elective cases, if there is no very minimal risk, we use second generation supraglottic airway devices, right? It is comparable to ET tube in preventing aspiration. So this is all about our supraglottic airway devices. Now let us talk about some surgical airways, right? Surgical airways like your surgical tracheostomy or cricothyroidotomy, right? So your tracheostomy, the surgical tracheostomy, we can also do non-surgical tracheostomy like percutaneous tracheostomy. So we'll here talk about tracheostomy and something called cricothyroidotomy. Now this is airway securement in emergency. This is done in emergency when we cannot intubate, cannot ventilate. Emergency during unable to intubate, unable to ventilate. Unable to intubate and ventilate. Okay. So cricothyroidotomy, let us first discuss it. So we know this is your thyroid cartilage and this is your cricoid, right? In between them is your cricothyroid membrane. This is the cricothyroid membrane. Okay. When we pierce, this is a very easy membrane to pierce, right? This is thyroid prominence, this is the cricoid, in between is cricothyroid membrane. So what we do, we take a needle, a thick bore needle, right? For needle cricothyroidotomy, for needle cricothyroidotomy, we take the needle and we pierce the cricothyroid membrane, attach it with a 2 cc syringe and a connector, and we do the ventilation. So that is called needle cricothyroidotomy with large bore cannula, largest bore cannula which you have, like your 14 gauge or 16 gauge. Then we can also go for the surgical cricothyroidotomy, surgical cricothyroidotomy. In this, or we call it tube cricothyroidotomy. In this, we can use a set through which we can insert the cricothyroid membrane and properly put a smaller size endotracheal tube through it. Okay, so this is cricothyroidotomy done in emergency. Done in emergency. Remember, it is done in emergency, and this is just a temporary way of securing the airway for ventilation, not a definitive management of airway. Okay, for definitive surgical airway, we have to do tracheostomy. Now, how do we do tracheostomy? Tracheostomy can be done surgically or it can be done percutaneously, and this is a tracheostomy tube. Tracheostomy tube. Okay, so tracheostomy tube can be inserted. We can do surgical tracheostomy or we can do percutaneous tracheostomy. Okay, or percutaneous tracheostomy or surgical tracheostomy. Now, for both we are inserting this tracheostomy tube. For tracheostomy, we have to insert the tube between second and third tracheal ring. So, if I compare with cricothyroidotomy, we are putting the needle in between thyroid and cricoid. This is the cricothyroid membrane high up in the neck. For tracheostomy, just 1 or 2 centimeter above the sternal notch, so low in the neck here. This is the point for tracheostomy. This is the point for cricothyroidotomy. So if in exam image-based question is asked and the needle is inserted high in the neck between thyroid and cricoid, it is cricothyroidotomy. Low in the neck, it is tracheostomy, right? Tracheostomy is more of a elective procedure, right? Tracheostomy tube is inserted between second and third tracheal ring, and it is more of elective procedure, planned procedure. Okay, now let us talk. So this is the tracheostomy tube, one of the tracheostomy tube with the cuff. So let us talk about few different type of tracheostomy tube which is asked in exam. So we have cuffed tracheostomy tube, as you can see here. This is used for positive pressure ventilation. For positive pressure ventilation on ventilator in patient in ICU, right? Tracheostomy, when we have to go for long-term mechanical ventilation, we change the cuffed endotracheal tube to cuffed tracheostomy tube. Then if this is not there, then cuffless tube, uncuffed tube. So uncuffed tube is used during weaning from the tracheostomy tube, or decannulation, used during decannulation when we are removing the tracheostomy tube from the patient. Okay, it is not used during mechanical ventilation. We need a proper seal by a cuff for mechanical ventilation, which is not there with uncuffed tube. Then we have fenestrated tube. Fenestrated tube, there are let's say there are openings in the tube. This is for the air to pass, and this is when we are encouraging the patient to speak up. Okay, so fenestrated tube, there are openings in wall of tube. Now this is used for voice production, right? So when the patient is encouraged for voice production, this is used. But number of time there is a risk of aspiration when we are putting fenestrated tube, on risk of let's say granuloma formation. Then we have metallic tube. Metallic tube is not used for in patients who are on ventilator, because they don't have a connector for ventilation. They are only used when patient cannot maintain the airway for some reason mass or tumor but can breathe. So this just creates patency. This can be removed, washed, and then again reinserted in a patient. So metallic tube is used for long-term tracheostomy in patient not on ventilator, okay, just to keep their airway patent. Okay, so these are the different tracheostomy tube. As I told you, this is more of elective procedure. Let me compare it. Cricothyroidotomy, this is quick, relatively easy, and this is an emergency procedure. Tracheostomy, this is a hole between second and third tracheal ring. This is not emergency and it is more of the elective procedure, and if you will do it in emergency, there's a risk of lot of complication associated with it. So in emergency, we only go for cricothyroidotomy. So these are the difference between cricothyroidotomy and tracheostomy. So this is all I want to talk about in the surgical airways and the airway. Difficult airway management, I will discuss as a separate topic in complications. Thank you.